Greetings, I'm Dr. Kim Yong-jin. For successful GBR, surgeon's technique is important, but also important is in what environment, what membrane needs to be selected. There are resorbable and non-resorbable barrier membranes used clinically. Here, I'm going to talk about the selection and clinical application of resorbable membrane. This is the contents of today. First, clinical application of barrier membrane. When and how we can use them. The main topic is the characteristics and clinical application of resorbable membrane. First, let me talk about the selection criteria of choosing barrier membrane. A basic principle of GBR is to block the entry of soft tissue cells using barrier membrane into the bone graft. For that, barrier membrane is essential. Cell occlusiveness is the most important role to block the soft tissue cell ingrowth, so bone can be formed from the bone margin to the defect area. Some dentists may think periosteum can be the best membrane. That's right. If periosteum is intact, it can be a good membrane. However, in the environment where we do GBR, we are not sure of the status of periosteum to cover the graft material. This is a study paper on that. In one group, bone graft is covered with the membrane. In the other, periosteum is used to cover the material. The volume of graft material is measured accurately using prefabricated stent. If you look at the graph on the right, the group which did not use the membrane showed bone resorption. Even the existing bone is resorbed. In other words, for better prognosis, it is better to use the barrier membrane. Regardless whether the periosteum is intact or not, barrier membrane can give a better prognosis and more stable bone regeneration. As I said before, barrier membranes on the market can be classified into resorbable and non-resorbable membranes. Let's look at when we use resorbable or non-resorbable membrane. Can we always just use resorbable membrane? This is a relevant paper. Conclusion: when we choose a membrane, we need to choose an appropriate one fitting the clinical situation. Resorbable and non-resorbable membrane characteristics and benefits need to be understood so that appropriate membrane can be chosen for an appropriate clinical situation. This is my clinical know-how. When an implant is placed within bone envelope, as you can see in the photo, I use a resorbable membrane. An implant placed in the bone envelope means the alveolar bone appears okay. However, there is a local alveolar bone defect where the implant is placed, and you don't need the alveolar bone augmentation. Along the alveolar bone, we need to improve the bone. Then resorbable membrane is good enough. However, as you can see below, there is horizontal and vertical bone resorption to create bone support around the implant. Overall, the bone augmentation needs to be done. For this, a non-resorbable membrane is indicated because it is much more rigid than the resorbable one. Recap: if an implant is placed within bone envelope, resorbable membrane is used. If an implant is placed outside the bone envelope requiring alveolar bone improvement, I would use the rigid non-resorbable membrane. First, the resorbable membrane. It is very soft, easy to handle, so many dentists like to use it. However, there is a fatal disadvantage. As it is soft, there's no capacity to maintain a space under the compression of the soft tissue above. So, as I said before, the resorbable membrane's first indication is to use it when an implant is placed within the bone envelope without requiring the alveolar bone improvement. Resorbable membrane can be adapted to any defect that doesn't need to be fixed. It is easy to use. Some dentists say different membrane should be used depending on the size of a defect, but I don't think so. As you can see, in this case, 2 implants are placed in a large bone defect, and the 2 implants are within the bone envelope. Overall alveolar bone appearance does not require improvement. So a resorbable membrane is used even though the defect is big. 4 months later, in the second stage of surgery, you can see very well regenerated bone. Let's classify the resorbable collagen membrane in more details. Cross-linking, whether it is cross-linked or not, the resorbable membrane can be classified. Natural collagen is not using cross-linking, and there is cross-linked collagen. What is the reason for cross-linking? As you can see in this same image, cross-linked collagen has more dense structure, so tensile strength would get changed. During handling, it doesn't get torn apart easily. When it is wet, the tensile strength is much more higher in the cross-linked collagen membrane. So when it is hydrated, clinically it is less broken and the resorption period can be lengthened. That is the advantage. Currently on the market, there are various cross-linked collagen membranes, and this is a study on the methods of cross-link. Formaldehyde or glutaraldehyde chemicals are used. That is an easy way to manufacture it. However, when formaldehyde or glutaraldehyde are used, after collagen is resorbed, the chemicals would remain in the GBR sites, causing inflammatory reaction on the gingiva above from time to time, like this. This is a case reported in a paper. So, in an aesthetic area like maxillary anterior, I use a collagen membrane that is not using chemicals. So my favorite is the OSSTEM membrane. It is manufactured by a BioLand in Korea. It is not using chemicals but the physical method. The hydrothermal treatment is used, meaning it is dehydrated at high temperature. Collagen is cross-linked physically, which is good for soft tissue and the bone regeneration. It is available through OSSTEM as OSSGuide. However, regardless of the cross-linking, collagen membrane has a disadvantage: lack of space maintenance. When it is exposed, it is degraded and it cannot work as a barrier membrane. Once the collagen membrane is exposed, it no longer serves as a barrier membrane, interfering with the bone regeneration below. As you can see in this paper, histologic picture, When collagen membrane is exposed, epithelialization occurs well above. As you know, collagen is used as a dressing material for soft tissue, but during GBR, it is not used for epithelialization. It is used to facilitate the bone regeneration below. Then, how can we use the collagen membrane in a clinical situation where primary closure is hard to achieve? So, today I want to introduce the non-submerged type of GBR. As you can see in the photos, the GBR, a lot of bone graft is done on the buccal side of the implant. A healing abutment is mounted, no cover screw for primary closure, and you can see bone is very well regenerated. After I realized this technique, I realized the new world of GBR. So this is like innovation of GBR. I'm going to introduce the non-submerged GBR technique. Transmucosal GBR, which is also called non-submerged GBR, is to address a problem of tissue-level implant, which is hard to achieve a primary closure. It is hard to submerge the tissue-level implants with the transmucosal part during GBR after placing it in a bone defect. So the collagen membrane is trimmed around the transmucosal part, and below it, the bone graft is put in. The primary closure was done on the transmucosal part. And very good bone regeneration was reported by Nicolaus Lang in 2001. That means it doesn't need to be completely submerged around the healing abutment if you can do the primary closure. If you can get the circular approximation around the healing abutment, the bone regeneration's prognosis is not bad according to this scientific evidence. Why? We know mucosal sealing occurs between the healing abutment and the marginal gingiva. Of course, it is different from natural tooth. There's no structure cementum, so collagen fiber cannot fill the gap between the healing abutment or abutment. But hemidesmosome mechanism make the mucosal sealing occur to a certain degree between the marginal gingiva and the healing abutment or abutment. If we can get enough mucosal sealing, bone regeneration can be ensured. Let's look at a case. 34-year-old female. She was referred to us to extract number 11. And the treatment was provided due to a trauma at a young age. On the apical side, the lesion is formed again. She was referred to our hospital for extraction and implant placement. Pre-op photo. The bone defect below is quite large. The soft tissue level is pretty good. Marginal gingival recession or fistula on gingiva was not observed, so we plan to have immediate placement after extraction. If you compare 11 and 21 on the CT, 11 has pretty large labial bone loss. After extracting number 11, distal single vertical incision is made. Triangular shaped flap is raised, and an implant is placed after removing the granulation tissue. There was a big defect buccally, but the palatal bone was intact, so the drilling was done palatally and implant was placed. It is placed about 4 millimeters below the interproximal bone level. After that, as I said before, OSSTEM, the collagen membrane is trimmed and holes are made so that a healing abutment can be connected. So it is connected. Before bone grafting, the membrane is fixed to the implant using the healing abutment. After that, the xenograft fill below overall defect area. The overall graft site is covered with the collagen membrane. You can see the fixed healing abutment. Around the healing abutment, primary closure was done. If you do primary closure after it is completely submerged, 2 vertical incisions should be made and the vertical flap should be coronally pulled. Then the 2 vertical incisions would leave scars, and the mucogingival junction would move coronally, lowering the soft tissue aesthetics, which will also require a second surgery, during which additional soft tissue treatment would be required, such as apically positioned flap or free gingival lift. But in this case, the raised flap is repositioned in the place using suturing. Panorama, PA, CT. As you can see, the implant is placed palatally to secure enough thickness of bone graft material. For the temporary crown, the healing abutment is removed after the surgery using an impression coping. Implant level impression is taken, and a model is made and a screw retained type temporary crown is fabricated. So we try to make the cervical gingival contour more aesthetic. The stitch out was done post-op 2 weeks. The screw retained provisional crown fabricated in a lab is connected. Post-op 14 weeks before the final prosthesis delivery, you can see the contour of the gingiva is very good. A closer view of gingiva contour. After the final prosthesis delivered, 1 year follow-up. As you can see, there was a big defect, but GBR was easily done without lowering the aesthetics of soft tissue. If you use a resorbable membrane like this, you will be able to do GBR easily. A final case, in the mandible, many teeth will be extracted and 6 implants will be placed. All teeth except the lower bilateral number 7 are extracted and 6 implants are placed. A pre-op photo. As you can see, the apical side of number 33, a fistula is observed. On the CT, buccal bone loss is observed at number 33, which must be the reason for the soft tissue fistula. After extraction, 6 implants are placed at number 3, 4, and 6 on both sides. Due to the existing labial bone defect at number 33, the buccal implant is exposed. The GBR is necessary. In this case, the implant stability is good. For immediate placement, soft tissue is not sufficient. In this case, transmucosal GBR is indicated. A resorbable collagen membrane is trimmed. Holes are made to connect the healing abutments, and it is fixed first. After that, the membrane is raised. The autogenous bone harvested from the adjacent extraction socket is put in around the implant. Xenograft is put in on top of it, and the site is covered with the membrane. Surrounding the healing abutment, a primary closure is performed. It is not completely submerged, negating the secondary stage surgery, which is a big advantage to both doctors and patients. Post-op panorama. Post-op CT. As you can see, the labial buccal bone graft of the implant is well maintained. The bone graft is maintained without a problem, even though the healing abutments were connected without submerging them completely. Post-op 6 months, final prosthesis was delivered, and follow-up photo. At number 33, where GBR was done, the horizontally augmented alveolar bone volume is maintained. 6-month follow-up CT. On the CT, you can see the buccal wall is augmented and very well regenerated. Xenograft outside is maintaining the volume. Inside, autogenous bone is turned into the patient's bone. Let's compare them over the passage of time. At number 33, which had a large labial bone defect, after the surgery, the bone graft around the implant is pretty much stabilized. Inside, you can see the cancellous bone. Outside, ideal cortical bone is made. At this lecture, I talked about the resorbable membrane. At the beginning, I talked about the clinical application, the selection of barrier membrane, when to use resorbable or non-resorbable membrane. When we have to use a resorbable membrane, when the primary closure of soft tissue is hard, transmucosal approach can be used. For successful GBR, when we choose a membrane, we need to consider many factors. The characteristics of membranes and limitations of them need to be understood to select the appropriate membrane for good indications. So today I talked about transmucosal GBR, and I hope this helps your journey to find easier to do and more convenient, successful procedure. I believe various surgical and clinical materials are uploaded to the dental site. You can search information at the dental site. If you are further interested, you can take a master course with hands-on so that your clinical skill can be enhanced. This concludes the lecture. Thank you very much for your attention.